This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. All right, welcome everybody to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. For those of you who are new, welcome. For our regular listeners, welcome back. I'm a MedPeds trained pediatric hospitalist coming to you from Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. Now, this is our 10-year anniversary of the podcast. We started 10 years ago, actually in October, so we're a little off, but we're getting there. So it's a big deal year, so we're going to have some stuff coming up that you're going to be excited about over the course of this year. We have a couple of big podcast episode series, which we'll talk about more. And I'm sorry I've been gone so long, since August was our last episode, but I had some personal issues, which I am not going to discuss, that took some time. And now we're back, and we have a great episode to come back to. So to give you an idea of what we're going to talk about today, as you know, I'm clearly a pediatric hospitalist, and we often diagnose kids with diseases in the hospital. And at our grand rounds at Children's Hospital of Pittsburgh, we had our next guest, Dr. Michael Dollinger, come, and I was genuinely blown away by what he talked about in terms of diagnosing inflammatory bowel disease. So before we start talking, I need to introduce him. So let me dive right in. Dr. Dollinger is the director of the Pediatric Inflammatory Bowel Disease Program, the Associate Program Director of the Pediatric Gastroenterology, Hepatology, and Nutrition Fellowship, and an Assistant Professor of Pediatrics at NYU Grossman School of Medicine. He received his medical degree from Albany Medical College and his MBA in Healthcare Management from the Union Graduate College. He completed his pediatric residency at Cohen Children's Medical Center in Long Island, New York, where he then served as chief resident of pediatrics. Completed clinical fellowship in pediatric gastroenterology, hepatology, and nutrition, and his advanced inflammatory bowel disease fellowship at the Icahn School of Medicine at Mount Sinai. Dr. Dollinger's clinical and research interests include improving the quality of care and outcomes for children with IBD. He's led the adoption of intestinal ultrasound, which is why we have him on, for children and adults with IBD, co-founding the Intestinal Ultrasound Group of the United States and Canada, IUSCAN. He now leads global training, education, and research efforts on the use of intestinal ultrasound as a non-invasive monitoring tool in inflammatory bowel disease care. He also focuses his research on the efficacy and safety of novel advanced therapies in children and adults with IBD. So this is an exciting new topic for us, and I'm very happy to welcome you on, Dr. Dollinger. Thanks for joining us.
Thank you so much for having me. Very excited to be here.
All right, Mike, we're going to do our disclaimers first. I'll go first, kick it out to you. Since we're a CME podcast, we have to disclose anything we have. I have nothing to disclose.
I'm a consultant for several companies: AbbVie, Pfizer, Johnson & Johnson, Celltrion, Takeda, Sanofi, and Samsung.
All right, so I have to tell you, I went to this grand rounds. I was blown away by the information because I did not know that there was such advances in diagnosing and managing inflammatory bowel disease. We see it a lot at the hospital. So I would love to set the stage before we talk about what you've done. So for our listeners who either are trainees, et cetera, prior to your work or the work you really kind of helped pioneer at the United States, how did we diagnose inflammatory bowel diseases like ulcerative colitis and Crohn's disease?
In inflammatory bowel diseases, Crohn's disease, ulcerative colitis, two of the spectrum of them, are chronic immune conditions that were historically only diagnosed by colonoscopy and tissue or biopsies, histopathology, and imaging, cross-sectional imaging, combined with that in the form of radiation imaging with CT. And now most patients got an MRE without radiation. And so this was, and still is, the dominant way in which we diagnose and manage and evaluate inflammatory bowel disease in the United States. You give me a lot of credit to pioneer work, but I would say still, despite the push and the advances, and you brought up earlier off camera that this is at Pittsburgh now, or what we're about to talk about, it still actually does not reach the majority of IBD patients, or even 90% of them in the United States. So there is still a long way to go, especially in pediatrics.
So do you find that the major resistance then, because, well, let's back up for a second. Getting an ultrasound is a lot faster, easier, cheaper than any of the other techniques that you talked about, especially scoping, which you have to sedate for, and MRE. So is the resistance at this point data of the efficacy, or is the resistance more knowledge that this works, or training? What would you say?
I would say it's multifactorial, that it's hard to change care. There's an inertia against change, especially when thought leaders in medicine are typically been in practice for 10, 20, 30 years. They may incorporate new evidence and new ways of doing things, but to dramatically change the way an entire field practices, let alone one individual or one center, and many individuals in that center, takes a Herculean amount of effort. And now I realize how much people underestimate that inertia that you have to push up against to truly change care. So I, in 2019, was the first person in the United States to learn ultrasound in the diagnosis and management of IBD. Simple, traditional abdominal ultrasound, no drinking, no contrast, no fasting. Something that you would think would be everyone would want to learn and do. But I would say for 3, 4 years, that was met with skepticism from 99.9% of people. This will never take hold. This is not reproducible. It's not accurate. It's not reliable, despite European data and other data suggesting otherwise, multi-center and high-quality data. People wanted to see whatever data they wanted, and didn't care about anything new. I would say fast forward to all of a sudden you start to do it, and patients are the one who actually drive care and innovation. I realized the power of social media and innovate, and how they spread and talk. You start to do it in your own patients. You start to realize the impacts it makes. And then you actually don't care about the naysayers and what people who are skeptical will say. You realize how impactful it actually is, and that's all that matters. And then the patients talk. They go on their groups and they say, hey, this person's doing ultrasound for me in this center. Why isn't my doctor doing ultrasound in my center? And then they say, well, we don't do that. And then another patient says it, and another patient says it, and another patient says it. And all of a sudden they say, well, maybe we should probably look into that. And then they look into it and they still are like, oh, it seems like a lot of work. But then they realize, oh, another center's doing it, another center's doing it. And it becomes like this rolling ball where they have to pick it up. So it becomes less about that it's better than colonoscopy or easier to do, and more about that it's patient driven. Patients see the results on the screen. They realize it's actionable. They know what's going on in their body and they know it's the truth right there. And so once that happens, that's how I know this will become the standard of care. And now it's just up against the barriers of training and educating and incorporating it into guidelines and making sure we can meet the demands. But it will happen. Whereas maybe 5, 6 years ago, this was all about, can we convince 1, 2, 3 more people to do it? And now we're past that point, which is good. So didn't really answer your question, kind of a whirlwind answer, but it's kind of setting the stage for a little bit of where we are in the diagnosis and utilization of ultrasound.
You said something I want to touch on. In one of your review articles, an article titled Review Article Extending the Frontiers of Intestinal Ultrasound Knowledge, Performance, and Expansion. And the first author was a Dr. Kathy Liu. And this was in Alimentary Pharmacology and Therapeutics, published November of last year. You kind of went into your authorship group that you're a part of, went into the fact that this has been done in Europe for an extended period of time before we started doing it. And there's a lot of data from European studies that this intestinal ultrasound works to diagnose and manage. How long of a period of time are we talking about that this has been used in Europe?
So ultrasound, the first studies, I can't quote them, but I don't know them off the top of my head. They're actually Italian studies. The Italians and the Germans argued who did it first for IBD in the 80s.
Oh, wow.
So it's been about 40 years. But it wasn't until 2017 when an international group called the International Bowel Ultrasound Group formed, of a collective group of Europeans, Canadians, Australians who were actually doing this and decided to standardize the protocol. Because a lot of people were doing ultrasound, but they were doing it their own way. There was no standard formal protocol training, and the research as a result wasn't the highest quality, even if it was multi-center. I'll say all this is true, but children, and this is a pediatric podcast, were not part of that research. And in Europe, pediatric gastroenterologists and pediatricians did not learn ultrasound for IBD. And that is still true to this day. We are actually, for some reason, adult gastroenterologists learned as part of their training in Europe, Italy, Germany, places I just brought up. But in the United States, we actually have more pediatric gastroenterologists who do ultrasound for IBD than they do in Europe. So it's quite remarkable. Why I'm not sure, and the use case is better in kids than it is in adults.
I wonder, we're definitely in pediatrics more used to ultrasound than the adult side. We use them a lot. So can we get into some of the data that you have or that you either been a part of or know of that tells us that using ultrasound to diagnose and manage inflammatory bowel disease is as good as or better than traditional methods?
Yeah. The first thing is that inflammatory bowel disease is transmural, meaning it affects all four walls of the intestine, whether it's colitis, which you learn in med school as a mucosal disease, not true, or Crohn's disease. It affects all four walls. When you do a colonoscopy for diagnosis, you're just seeing the inner lining, the mucosal layer. And when you get tissue, you don't see all four walls. So patients can have very mild inflammation on the inner lining, but they miss the severe inflammation, thickening, swelling of the entire wall without doing cross-sectional imaging. Cross-sectional imaging like CT and MR is actually not very accurate for the colon. It's very accurate for the small intestine, but it's not very good at detecting inflammation in the colon because patients have to drink contrast. It needs to get all the way to the large intestine through the small intestine and needs to distend the colon, which it really doesn't actually do. And so that imaging is not very sensitive for it. Ultrasound doesn't rely on any contrast and is very sensitive to detect inflammation in the colon. We've been able to study this multiple times. We published in 2023 in the American Journal of Gastroenterology on the accuracy to detect inflammation in the colon itself in kids specifically. And it's the most accurate test you can do, more accurate than MR, CT, blood tests, stool tests for detecting inflammation. The key to inflammatory bowel disease is we are not very good at treating it either. Our medicines are not that effective. And part of that is because we're not so precise at monitoring it and kind of mapping all the inflammation. Having a transmural way to do this, which is more accurate to disease, is the best way to map inflammatory bowel disease. And looking at the entire transmural nature changes how you might think about someone's ulcerative colitis when you see that their entire colon is actually very thickened and it's just as limited to the inner lining. It makes you understand why using a treatment that just goes after the inner lining may not be very effective. But most people don't have this view. So this wasn't shown how accurate this was to colonoscopy, especially in kids, before we did it. And now there's really two major studies in the colon, one by us, published in the American Journal of Gastroenterology, that I said in 2023, another one by Mallory Travan in Inflammatory Bowel Disease Journal, I think published in 2024, which highlights that ultrasound is extremely accurate in kids who are undergoing colonoscopy for screening for inflammatory bowel disease.
And what did you, in those studies, or either one of them, what did you compare the ultrasound to? What was your control group?
Yeah, that's the hard thing. So we only had kids with inflammatory bowel disease, and we're using colonoscopy as the gold standard. So then the question becomes, what's correct? If ultrasound shows thickening, but the colonoscopy is normal, does that mean that that patient doesn't have inflammation? I would argue that's not the case, because patients can have transmural inflammation without having mucosal inflammation. And we know in adults with Crohn's disease, there are studies showing, one by Emma Calabrese in Italy, 2021, one by, I forget, someone else in 2019 that show if you have transmural inflammation, either on MR or ultrasound in Crohn's disease, and you have normal endoscopy, but there's thickening, you will have worse long-term outcomes, more hospitalizations, more need for surgery, more emergency room visits, more steroid use over time. So we know that this is a better target to treat transmural rather than mucosal inflammation. So we didn't have a comparator group, but you can argue that the gold standard of colonoscopy maybe will change over time to be actually a full mucosal and transmural assessment, and not just this mucosal assessment that we compared to.
And you're saying that CAT scan, is the MRE more sensitive than the CAT scan?
No.
No.
MRE and CAT scan are pretty similar. And especially when you take it on an individual patient level, it's just an MRE does not have radiation, which is the main advantage. There are certain centers who have different protocols, and maybe MRE is slightly more sensitive. But really, when it comes down to detecting complications, fistula strictures, they both have the same accuracy.
And you said something we kind of glossed over, and I want to focus on it a bit. We learn as med students, and our med students are still being taught, ulcerative colitis is kind of is not a full thickness disease in terms of the bowel wall, whereas Crohn's is, and Crohn's has skip lesions, where ulcerative colitis typically goes in a kind of consecutive fashion. And you're saying from your research that that's not exactly true.
Yeah, whatever the opposite of exactly true is, it's not correct at all. All ulcerative colitis has transmural inflammation. There is no ulcerative colitis with just mucosal inflammation. And the textbook learning as a key differentiator from Crohn's disease is that Crohn's disease is transmural and ulcerative colitis is mucosal. It is true that ulcerative colitis is continuous, as you say, and Crohn's disease can skip. But it is not true that ulcerative colitis is not transmural. It is, in fact, every time, and it's not the mucosal layer that drives inflammation. It's actually the submucosal layer in ulcerative colitis that drives all the inflammation. We learned this through ultrasound. We learned it through, there are a couple studies. My friend out of Amsterdam, Floris de Voogd, DE space VOOGD, has a few publications in IBD, Journal Crohn's and Colitis, that show the submucosal layer is the main driver of inflammation. And when you have patients who don't respond to treatment, it's because it's the submucosa that's thicker in those patients with ulcerative colitis than other patients who do respond. And it's not about the mucosa, which is completely different than anything we learn in med school.
Yeah, I mean, we're still teaching other
Yeah,
stuff.
we still teach it. It's crazy.
So for this is a hospitalist podcast, right? And so what typically happens at any of the major pediatric hospitals across the country is if a patient comes in and has signs of IBD, significant anemia, blood in the stool. In pediatrics, it could be weight gain issues, short stature, maybe extraintestinal management. This patient could be screaming inflammatory bowel disease in terms of clinical symptoms. You consult GI if they come on a PHM service. GI has to see them. They usually want imaging, typically an MRE. If there's already been imaging, a CAT scan, they still want the MRE sometimes. And then they'll schedule them for colonoscopy and endoscopy in the suite. And that may take days to get. First, they got to get the time in. They got to do the prep. They got to get sedation, anesthesia. And so what you're talking about is significantly shorter in time. You're talking about consulting GI. Someone comes up with an ultrasound, does the ultrasound, and can tell the patient right then and there. Am I saying that correctly?
You are saying that correctly. It seems like blasphemy that if I'm on service, I'm going to get consulted. Even when we're going to recommend to send off stool infectious tests, we're going to show up with the ultrasound machine. And I'm going to know right then and there if this patient has an infection, if they have Crohn's disease, if they have ulcerative colitis, if they have both, with an extremely high degree of certainty, so much so that we're telling them this is the diagnosis. We still have to undergo these standard tests, not because we will use it to change management or recommendations, but because payers in this country need a diagnosis based on the current diagnostic criteria of tissue pathology for medication approvals, and they won't accept ultrasound otherwise. But in terms of hospital clinical management, we are absolutely hopefully being consulted in the ER, showing up with an ultrasound machine, and right then and there, knowing the differential in this patient. If IBD is considered, they should be ultrasounded at the initial consultation, as if they came into the office. It's People don't believe that it's actually like 90 seconds to be able
Yeah.
to know if someone has IBD. And we do it all the time. We'll stop someone from talking and say, we'll collect the rest of the history in the next 20 minutes. Let me just put the probe on you, and so we understand what we're talking about. And we know, oh, you have severe ulcerative colitis, or it's to the hepatic flexure, or it's left-sided, or it's Crohn's disease affecting 35 centimeters of your small bowel. We know that, right? Right there.
Now, how do you on ultrasound differentiate ulcerative colitis versus, IBD versus like a viral colitis? A patient has norovirus, which we're seeing a ton of, or whatever, rotavirus. How can you tell?
Yeah, this is where there's not great research. and it takes time. But when you have an infection, the colon becomes fluid filled. And even if it's thickened, it's really the mucosal layer that dominates that thickening from inflammation from an infection, whether it's viral or bacterial. Unless it's like fulminant C. diff colitis and it's very severe, you do not have this full thickening inflammation that's driven by expansion of the submucosa and muscularis propria layers of the bowel wall in a virus or a bacteria. The difference with ultrasound and other imaging modalities, even if they were accurate to see thickening and swelling of the colon, let's say, for example, of CT and MR, which they're not, ultrasound is the only one that can view the individual bowel wall layers because it has the highest resolution to the 0.1 millimeter. Those other ones have a resolution to 1 millimeter, and often the layers are not that thick. So ultrasound can always differentiate between these layers. And as a result, we're able to kind of classify this right on the spot as inflammatory bowel disease with almost perfect level of confidence.
Now, those of us who don't do this type of imaging, I had no idea the ultrasound resolution is finer than a CAT scan or an MRI in terms of down to the millimeter.
Yeah, it's 1,000 times the resolution. So I compare it to taking a magnifying glass and looking for ants on the ground is what I'm doing with ultrasound versus when I have an MRI, I am flying in a helicopter above a city taking a tour. And that's the difference of what I'm looking at. So you can lose the forest through the trees, especially as you're learning with ultrasound because you're looking up so close and you're getting such an intense granular view. But that changes over time. And you can learn a lot about the pathology of disease when you get that kind of information.
Now, you said there's not a lot of good data for this, but is there more data? Is there more research in the works to help create guidelines for when it could be more viral versus IBD, or is this from your experience?
It's from my experience. There is research in the, we're still so far behind as a field. We're trying to get this into IBD guidelines. It is not in any form of pediatric guidelines in the United States. It's now finally in even IBD guidelines in adults, which took a Herculean effort. And again, you'd think pediatric gastroenterologists would want to put this into guidelines, given all the evidence that's come out. We have a lot of papers now, good data, and it's becoming widespread in use, but we still lag so far behind and we're so slow. To then think about translating this to, it may be faster to get into hospital medicine kind of guidelines and infiltrate those fields where POCUS is well more established than in the field of pediatric GI. Because I do think, this should be used, and it doesn't need to be a gastroenterologist doing it, as a screening test by everyone. If someone comes in with diarrhea, rectal bleeding, weight loss, anorexia, abdominal pain, they should all have an ultrasound, intestinal ultrasound looking for IBD.
Now, you said POCUS. Can you use one of these pocket point of care ultrasounds to do this, or do you need like a bigger screen?
You can. You can use a pocket point of care ultrasound. The difference between the bigger models, starting at ones that cost $30,000 or $40,000, go up to $180,000, are that they're more forgiving. They often just have more features and bells and whistles, but they also have higher processing power, and the images are crisper. The blacks are blacker, the whites are whiter, like buying a fancy TV versus an older one. The handheld technology is catching up. There's actually a couple studies that show this. One Italian study that shows that it's accurate especially in severe ulcerative colitis. And if someone gave me a handheld right now, I'm very confident that I could detect the same amount of inflammation I could with the largest machine. It becomes a little technically challenging when you have to hold your hand on a probe and then a hand on an iPad, kind of thing. But that's the drama of it, really.
How often are your ultrasound findings equivocal? Meaning you're not. Are you often ever getting equivocal results where you're not sure?
Yeah, nothing's perfect in medicine, especially. I would say it's exceedingly rare, though. We are perfectionists in our field because we think we can get better outcomes for our patients. And so when I'm not 100% sure, we'll have the conversation with them like, hey, we're 90% sure. This is the possibility. Here's the 10%. Do we want to go do a more invasive test, or do we just want to repeat this over time? But that's pretty rare. When it's normal to mild to moderate inflammation and not just like, almost mild, we can distinguish it with 100% accuracy pretty much every time. And especially when it's moderate to severe, we're always accurate in detecting that. So it's really not equivocal very often. I'm trying to think of a case recently where I thought, oh, this isn't telling me everything I need to know. Um, I can't really think of one.
But surely anyone coming to us as pediatric hospitals, being admitted, having symptomatology bad enough to be admitted, you would say is moderate to severe, especially in the case I presented, a patient with anemia, abdominal pain, trouble with growth. That one should be more moderate to severe, being that they're at the point where they're being transfused coming to the hospital.
Oh yeah, and imagine you're that patient who then has to be told, great, let's do an MRE, let's do a
Yep.
colonoscopy, drink a bowel prep, and I'm vomiting and I'm in pain and I'm suffering and I'm anemic, and those a colonoscopy is not without risk in that patient, and or you can just have an ultrasound for 15 minutes on your belly, and maybe pressing causes a little more discomfort, but usually not, and we can know the exact same information. A rational patient, adult or pediatric, will choose the ultrasound every time. And for me, that's like the use case. It's like, what would a patient want? Okay, a patient wants the ultrasound. So that's the test that makes sense.
Now, the data you went over also included outpatient data in terms of monitoring, which you've been kind of talking about now. Can you talk about some of the data you have where the monitoring of inflammatory bowel disease in outpatient for you as a gastroenterologist, ultrasound has significantly improved? I would love, because that helped really kind of sink this in. This is a great modality for me.
Yeah, one of the thinkings in IBD is that when we start a medicine, an anti-inflammatory treatment, whether it's steroids or newer medicines, we want to see inflammation heal. And we think it takes actually a long time for inflammation to completely heal. But when there's not a lot of chronic damage and we get the medicine right, it heals quickly. And we can now see that because we have ultrasound and we can do that repeatedly and very early. In acute severe colitis in adults, this is a paper out of Denmark. There are two papers by Ivelmark is the first author. Um, they are able to look within 48 to 72 hours of patients admitted, and they're able to see if changes in the thickness, and they are actually predictive of 1, 7-day colectomy-free survival, and 2, 1-year outcomes, being not readmitted, not having colectomies, and being in remission. We have a multi-center effort in the United States to do this same study in children, which is ongoing. But I can tell you, most pediatric gastroenterologists who do this in clinical practice will tell you that if there's a 20% improvement in bowel wall thickness or a 25% improvement in 48 hours, no matter how our patient's feeling, we know they're not going to go to colectomy. Outpatient, we were able to show the same thing in ileal Crohn's disease. It took a little longer, so it takes 8 weeks. Maybe if we look a little sooner, 6 weeks. But 8 weeks, we're able to see a 20% reduction in thickness predicts healing at 1 year with 100% accuracy. Every patient has 20% or more improvement in bowel wall thickness at 8 weeks, no matter what other factors are at play, how they're feeling, what their labs show. They go on to heal over time at 1 year by colonoscopy and ultrasound. And they're in clinical remission too. And we were able to show normal in ulcerative colitis is the same thing too.
And prior to the ultrasound, there was no other imaging modality you could use when you started treatment in ileal Crohn's disease to show that at 8 weeks out, we have a substantially decreased chance of having of this patient being or increased chance of this patient being in remission. There was nothing else you could do. You can't use CAT scan or MRE for that.
You could try, but no parent's going to take their I'm sure if they were able to do the studies to say, my 7-year-old's going to drink all this contrast repeatedly every 2 months to show this, but it's very hard to recruit for those studies, which
I can imagine.
it's just it's not ultrasound that's doing it. It's the medicine that's doing it, and it's an imaging modality showing that transmural healing in IBD is predictive of long-term outcomes. It can be done by MR and CT. Just no patient's going to tolerate it that often, and also then it's also expensive. Kind of the kind of thing. So, as a parent, I think about subjecting my child to that, and it's not something I would do. I believe that every proceduralist should undergo the procedures they're doing to other people or the tests they're ordering. For example, we're learning transnasal endoscopy here, so I had all the fellows practice on me. So, I really believe that MREs, other things, you should undergo it to know that it's not benign to drink that contrast, use glucagon to paralyze the bowel, and sit in that tube for, 45 to 60 minutes is pretty brutal.
So now I'd love to talk a little about the organization you founded, because there may be hospitals listening here, maybe community hospitals or academic institutions. We have both that want to learn more about this or get trained to be able to at least start doing this. So, can you talk to us about the Intestinal Ultrasound Group of the United States and Canada, how that came about, what it does?
Yes. So the acronym stands for IU-SCAN. And I love the name; it's hard to pronounce, but it works. So this is an organization that is a nonprofit organization that I helped co-found in 2024. It came initially from a grant from the Helmsley Charitable Trust that we were lucky to receive in 2022, with the goal of expanding research in ultrasound and IBD in the United States for both adults and pediatrics. However, it's hard to do research when nobody can perform intestinal ultrasound to begin with. So it really became more of a need for education and training. And as the grant finished, we realized we were not meeting that demand, and that a lot of the training that I had undergone in Europe and other places to do this and bring it back here was not flexible enough to meet the daily life of gastroenterologists, pediatric and adult in the United States. So we created this organization to really meet the needs of North American gastroenterologists. And we've floated around a few different methods of training, but really it takes adapting this to trainees first, who are the best at learning. They have the most time and their brains are malleable. So we have just now enrolled our first cohort of trainees. We have 30 third-year gastroenterology fellows, pediatric and adult, and fourth-year advanced IBD fellows from around the country starting in May for our one-year cohort of training. And we aim to scale that up pretty quickly. We had a demand of over 70 applicants. And then we're bringing it to community practices. We realize most patients are not seen in these big academic centers. It's nice to be Pittsburgh and NYU, but the majority of patients are seen in the local community, private practice, smaller centers. So we actually have, I just came back from Washington, D.C., where we did it for 4 providers in a small community practice that actually see a ton of IBD. So we have a multifaceted effort, and you can go to iuscan.org and read all about it for free. What the business model is, how we're training, how we're educating, what the program entails, and even see some cases and how it's used and what patients like, and a lot of recent literature we put up there as well. It's all for free and open access. So we want to spread information, and there's a provider directory in which if you're wondering, is this even at my center? Is there someone outpatient I don't know doing it? You can search you know, Pennsylvania in the state and see who's registered themselves as an expert in Pennsylvania. Maybe no one at this point, and you can see where people are on the provider directory.
That's fantastic. We'll put the IUScan website at the top of the podcast description. So if anyone wants to go to it and learn more about this modality, this sounds, for our patients, I mean, this sounds amazing to be able to diagnose IBD significantly faster, less invasive, less sedation, and ideally, this will catch on. As you said, this is slow going. If I had to do an over under for how long before you think this is standard diagnostic tools for diagnosing IBD in kids, what's your over and under for how long this is going to take?
Over under 6 years, we'll say.
6 years. Okay.
I think it will take 7, so I'll set the number at 6.
Okay. I mean, that sounds great, because that's first year med students. By the time they're midway through whatever residency they do, this will be changing for them. Now, that was all the questions I had, Mike, in terms of the data. I mean, the data was fantastic. I loved going to the grand rounds, and I recommend anyone listening. This is a great grand rounds. So please take my advice. It's a good one to listen to. And Mike and I never met each other, so it's not like we're old buddies. And I'm just trying to push him. This was great. Is there anything you wanted to talk about that I didn't bring up?
I would just say it's probably more likely you're a hospitalist or someone else listening, that the field has advanced so much and so many people have learned by just hearing something like this. And if you're consulting GI, just inquiring, hey, what can we do an intestinal ultrasound on this patient? Might that help? And if they say no, say, why not? They're doing it at these other centers. And then it just creates this, over time, this need for that institution to learn. And every single place that learns, there's another subset of patients that get this, another trainees that can come through that program and learn the tool, and helps expand the field. So I really value each person being able to ask and be part of getting this adopted, because that's probably what moves the field forward in reality.
I couldn't agree more. Now, I'm going to summarize what I think I understand about the pathophysiology of this modality in diagnosing IBD. You tell me how well I've picked this up. So basically, for the ultrasound-guided diagnosis, you can see the layers of the bowel wall, and so it's not just the mucosal layer, like for a colonoscopy, let's say, and you'll be able to pick up inflammation in the mucosal layer, but also the muscularis propria, the other layers of the bowel wall. So to diagnose inflammatory bowel disease, you can see that by using the ultrasound. You can see the inflammation quicker and easier. Clearly, no radiation, no sedation in a patient than in using an MRE or a scope, et cetera. And you can pick up perhaps disease that's not progressed to the innermost layer that you would see for a colonoscopy. How did I do?
That's pretty good.
That's pretty good. Okay. All right. And then this would differ. And then like for viral gastritis, which is a hospitalist we see a ton of, especially now, the difference is IBD is through the whole wall, viral colitis, norovirus, et cetera, is typically to the innermost layer. Is that fair?
Yeah.
And there's fluid.
Correct. And I would say if you have that patient who comes in and there's one red flag symptom that you're like, this doesn't seem like my typical viral or bacterial infectious case, that's where, it's huge. It feels like you feel like a superhero being able to come in with ultrasound and either provide the reassurance to someone that it is. And as a patient, that's what I would want. It's always in the back of my mind, is something else worse that's been going on longer than I think. Or, the confirmation that actually this is. We need to go down that workup much faster than we ever would have before.
Gosh, that's fantastic. Okay. Mike, I can't thank you enough for coming on the show. This is wonderful. I appreciate it.
No, thank you so much for having me. I love talking about this, so thanks again.
As a reminder, free CME is available, and it's courtesy of the University of Pittsburgh. Just click on the link under the podcast description and follow the instructions. Thank you to the UPMC Children's Hospital of Pittsburgh, and especially the Paul C. Gaffney Division of Pediatric Hospital Medicine.
Thank you again to our expert guests, and special thanks to all of you who take the time to join us. We know that your time is valuable, and we appreciate you sharing it with us.
Please feel free to email my dad at tony.tarchichi@chp.edu for any questions, comments, or podcast ideas.
As always, thank you for listening.